Next topic, guys, that is short bowel syndrome. So we talked about this bacterial overgrowth and now short bowel syndrome. Basically, it is a malabsorptive condition secondary to the removal of a significant segment of the intestine. So basically, it happens in the adults after Crohn's disease, mesenteric infarction, radiation enteritis, volvulus tumor resection. Or MD. Yes, yes. Okay. All right, guys. So, yes, we are talking about it. So, basically, what are the causes? Mesenteric infarction, radiation enteritis. Guys, radiation enteritis is also very much important. Valvulus tumor resection trauma. A degree of okay. So, guys, what is terminal ileal resection, and what is that? They say that basically it is removed, and then basically the what bile and water B12 is absorbed over there, and when it is not present, so no absorption of these, and we have just, side effect of all the fat soluble vitamins are absent in the body, and B12 is also absent. Okay, now they say that if the resection is over 50 of the ileum requires monthly subcut or IM vitamin B12. Okay, more than 50 subcut or IM vitamin B injection. If less than 100 of ileal resection, bile and malabsorption stimulates secretion from the colon, resulting in the watery diarrhea. This is treated with the bile salt binders like colestipol and cholestyramine. This is secretory diarrhea basically. So basically, watery diarrhea patient is having, and patient is having this problem with the absence of bile salts. So we do the treatment like this. And resection of, if now the first was less than 50, resection over 50, then we have to give vitamin B12. Less than 100, we have to give the bile salt binders. And when there's more than 100, then what we have to do? So it leads to reduction in the bile salt pool that result in steatoria and malabsorption of the fat. Vitamins is, we know treatment is low fat diet here and vitamin supplementations with medium chain triglycerides, which do not require micellar solubilization. So basically, we give the vitamins, all the vitamins to them. We say take low fat diet, and we give basically micellars of TGs. Basically, we give them. We don't need the silver. So this is some medication. I think so. It's oral. I'm not sure about it. And unabsorbed fatty acid binds with calcium, reducing its absorption and enhancing the absorption of the oxalate. And there is a development of, basically what happens that unabsorbed fatty acids, when they bind with the calcium and oxalate crystals are there in the patient and causes stones over there. So we have to give the calcium to bind oxalate and increase the calcium intake. So calcium should be given. Now cholesterol gallstones due to the decreased bile salt are common also. Okay. So in patient resection of the ileocolic valve, bacterial overgrowth may also be there. So we have to treat with the antibiotics in this case. Basically, this was nice. So we do according to the area of dissection of the terminal ileum. Now next is extensive small bowel resection. This is about more than 100 centimeters. I think so. I'm not sure. So they say that there's a massive which is called as short bowel syndrome. It is characterized by loss of weight, diarrhea, nutrition, fats, and electrolytes malabsorption. And over, yes, 100 centimeters or the proximal jejunum may be sufficient to maintain adequate oral nutrition with low fat, high complex carbs, fluid and electrolyte may still be significant. If the patient who has colon is removed at least 200 centimeters of proximal, basically proximal jejunum is a, like, it is a guide. We see from that. First was, if the colon is preserved 100 centimeters of the proximal jejunum, it is sufficient to maintain, it is good, and it maintains all the nutritions. Okay, so we have to say that patient should take with low fat, high complex carbs, and electrolyte, but fluid and electrolyte losses may also be happening over there. But when there is 200 centimeters loss of the colon from the jejunum, it requires oral nutrition and antidiarrheal agents like clopramide it is given, Or octreotide, it is also a good drug. It is given for to reduce intestinal transient time and fluid and electrolyte secretion. Now they say that gastric hypersecretion initially complicates intestinal resection and should be treated with PPI. So definitely we have to give the PPIs for that. So loperamide, octreotide, and PPIs, it can be given to the patient with the extensive small bowel resection. Now, the patient who has less than 100 to 200, this is the range of the proximal, almost require parenteral nutrition basically. So they say the patient with less than 100 to 200 from the proximal. So the decreased number, I mean quantity, diameter or the length, sorry, the length has been decreased to 10 to 20 from the proximal jejunum. That is very much less length. In this situation, what we have to give patient, that is glucagon like peptide 2, which is called as tegoglutide. Tegoglutide, guys, this is important. Know it. This glucagon like peptide, we have to give it when so much resection has happened. So they say that that stimulates small bowel growth and absorb, and it is FDA approved treatment for the small bowel syndrome. Okay, this tiduglutide. Okay, so now they say that when we use it, so there's a reduced need of parenteral nutrition. There's no need of like very much less. And small intestine transplantation reported 5 years graft survival about 40%. Okay, we can do the small intestine transplantation as well. Currently, they say that it is performed in the serious, it is performed chiefly in the patient in whom serious problems has happened due to the parenteral treatment. So yes, guys, we have done it.